So welcome everyone to the March 2021 Family and Community Webinar. So from all of us at RACMA, we want to say welcome to those who've joined us. If you are new to the webinars, and I see there's a couple people, RACMA is a small nonprofit with 4 homes located across the Minneapolis-St. Paul metro area. And our mission is that RACMA champions dignity in the care of individuals living with memory loss in a familiar home environment. So that's just a little bit about us. This webinar series is designed for family, friends, and interested community members. And really, we're focused here on presenting information and opportunities to connect with other folks who love those living with dementia, as well as to get some extra information and skills. Everything we cover in this webinar is not to take the place of professional medical advice ever. You should always double check with your medical professional about anything that you want to introduce or do something differently, especially if it's like a specific therapy or treatment that we're talking about. Please always make sure that you're double checking that. So the content really is here to just be some guidelines, some new practices to give it a try, and is always supplemental in nature. So the last little bit here is that this month's topic is specifically on trauma-informed skills. And this is a topic that is really near and dear to my heart because I worked with individuals living with and healing from different types of trauma for years. So this really connects to some of my favorite work to do, even though it's really hard work. So learning about the impacts of trauma, normal responses to trauma, and how to better support people who are living with trauma has so much connection to dementia care. And it's important to understand before we get going that trauma affects almost everyone that you will ever meet. There's usually some sort of trauma in people's backgrounds. Even though everybody experiences and processes that trauma very, very differently over time. So when we're talking about working with folks living with dementia, our loved ones living with dementia, we really want to make sure that they have caretakers and loved ones who know, can recognize, and successfully respond to trauma-induced distress by using the skills of trauma-informed care. So that's like a really good overview of what we're talking about today. But the very specific things that you're going to get out of listening today is you're going to be able to define what trauma is, as well as the different types of trauma that people can experience. You will understand the 4 F's of trauma reactions, identify connections between trauma and dementia because there's a lot. You'll be able to define what trauma-informed care is, as well as talk about the 6 principles that you use to be able to give that. And finally, we're going to talk about some pretty specific strategies and phrases to use when working with someone living with dementia to really help them kind of process through what's happening for them. So as always, couple of logistics for you all. So if you could please mute your lines until the end when we do questions that are out loud. You can use your phone or your web controls. If you've joined us on your phone, it's *6 to mute and unmute. The webinar is being recorded, so please know whatever you're sharing, it is being recorded and it is sent out afterward to anyone who couldn't make it live. We also post it on the RACMA Homes training channel on YouTube, and we put it on our website now, which is really exciting. You'll also get any additional resources that we talk about on the topic. So some months have more resources than others. Always know that your video is optional. You don't have to have it up. And go ahead and use your chat for any questions that you might have, especially as we're going through. I see we've already got some folks being able to use the chat, so please feel free to throw questions. I'll keep it up so I can keep an eye on it if you have something you want to ask before we get to the Q&A section. So a little bit about who I am. So my name is Johnanna Gans. Hello, Johnanna rhymes with banana. I am RACMA's training manager. I had the opportunity to join the RACMA staff in December of 2019. So I've been here for a little bit now. I'm feeling pretty settled and excited about the work that I do. So if you want to ever get a hold of me, if you have questions or want more resources, part of my role is to make sure that we're getting best practices and information to people. Go ahead and give me an email, or you can always give me a call at 612-564-3118. So let's just jump right into it. it's important that we start with a trauma 101 conversation. So these are kind of like key concepts to know and practice in your daily work in living with and loving a person who lives with dementia. So I do want to give a content warning for folks. Throughout the presentation, we are going to be talking about and mentioning traumatic events. So this is going to include a pretty wide range of different types of traumatic events. And these like mentions and discussions might remind you of difficult memories in your own past. So if you need to, go ahead, take a break, come back. It's being recorded and it will be sent out to you. So please, and if you're listening to the recording after, please pause the video as you need to take care of yourself, take a break. The content's always here, don't worry, you can come back. And there are lots of resources available. There's warm lines and crisis hotlines if you need that. So please make sure to take care of yourself through this process. So now that we've kind of gone through that, let's actually dig in. What is trauma? I think it's really important that we first define what we mean when we use the word trauma, because particularly in our cultural conversations, we use the word trauma for a lot of things. So our popular culture really says something is traumatic, even if it doesn't fit the psychological or the practical definition of what trauma really is. So we're going to take this moment and really take that closer look at the definition of trauma to understand what it is, how it happens, and how we can provide support to others when they're experiencing it or having memories of that experience. So it's important to understand that trauma can happen in a variety of ways for people. So first, it can be a single instance. So one thing that happens, it's one event. It can also be a series of events or multiple events happening closely together or even spread out. Or it can involve a specific set of life circumstances that result in ongoing harm to an individual or to a full group of people based on characteristics of things like race or gender or religious practice. Trauma, when we're trying to define it and use it as a term to describe very serious events in someone's life, is when the traumatized person experiences the harm, whatever that might be, as life-threatening. So the person thinks that they might die as a direct result of what's happening or that their life is in danger in some way. The other thing that we got to talk about in this life changing is that sometimes you can experience harm that is so disturbing. So it might not be life threatening, but it's so disturbing that it results in really long-term disruption to your daily activities. And that in itself is life changing. So really, when we're talking about what is trauma in the context of care, we're talking about something that radically changes a person, their experience, and how they view the world in a lot of cases. So what makes trauma a little bit different than just having a hard time or something really bad happening is that trauma overwhelms all cognitive, so our thinking, our emotional, and our coping capacities and tools that we currently have. So it takes whatever it doesn't matter how good your coping tools are, it doesn't matter how good your cognitive and emotional process is, trauma overwhelms that because it's so big, you don't know how to handle it. So this really does mean that we can identify trauma when a person does not have the resources, the tools, or the skills to process and respond what is happening to them in a clear, logical, being able to kind of contextualize it way. And that ultimately really does result in long-term effects. So because it's that life-changing circumstances, it really does change how that person experiences their own sense of well-being. It can impact cognitive and emotional process, as well as things like their social interaction. So experiencing trauma might change how someone is a friend or a sibling or a loved one or a spouse because it's so severe. I really love this little think box on the right side of the screen. It says the word trauma comes from the Greek word for wound. So it's evolved over the years to encompass both physical and emotional wounds. And I think that's a really important, just like if you don't remember this whole slide of information, just remember that it's a really serious wound that we don't have the capability to manage on our own. So let's talk about sources of trauma. It's important to understand the different types of trauma and the examples connected to those types of trauma to be able to develop your own coherent language. So being able to identify it and go, oh my gosh, that's type 1 trauma. It's going to give you some tools and skills to be more supportive because you understand the different events and how they've impacted that individual and how they might be reliving their memories, especially if they're living with dementia. So the important thing to know about all sources of trauma is that someone can be re-traumatized, their experiences can be re-triggered, even if they've had opportunities to meaningfully process the event. So it might be 10 years down the road and something comes up and you've handled it. You went and got resources, you got help, you might have gone to therapy or seen a medical doctor, depending on the type of trauma you've experienced. You're feeling really good about it. 10 years later, something happens and boom, you're right back there. We'll talk about the trauma avocado later to talk about what that looks like as a model. But it's just really important to know, even super healthy, functional human beings, it can come back for us. And when we're working with someone who is re-experiencing their memories in regression, it can really come back. And so we got to be able to name it. So the first type of trauma is called type 1 trauma. So this is really focused in on that single instance. And most often the medical diagnosis attached to type 1 trauma is PTSD, or post-traumatic stress disorder. So this is when there's a single event that causes devastation, is life-threatening or life-changing. These events can happen more than once in a person's lifetime. So, for example, you see car accident, you can get into more than one car accident in your life, but it's not connected, it's not ongoing, and it is not a clustered experience when it's type 1 trauma. So, some very specific examples just to kind of give you a grounding is that type 1 trauma includes car accidents, burglary, being a victim of burglary, being a victim of a natural disaster, sexual violence, or witnessing any sort of traumatic event happening to another person. So it could be a single instance, and you don't even have to be the one experiencing it. Witnessing it can also create the same set of conditions of trauma. So that's our type 1. Our next one is type 2. And I'm just going to spoiler alert, there's only type 1 and type 2, and then a third type that doesn't have a number attached to it. So type 2 trauma is the type of trauma that occurs when there is chronic, ongoing, or multiple traumatic events that are connected, clustered, or continuous. So that means there's no limit or there's no visible end to the experiences that are causing harm for that person. These traumas often involve a betrayal of trust in a primary relationship, especially if there's a caring component attached to that relationship. So some examples of type 2 trauma include managing a life-threatening illness, which hopefully that's already flagging for you as a connection to dementia, but it can be other types of life-threatening illness. It can be, for example, the experience of domestic violence, the ongoing neglect of children or elderly folks or vulnerable adults. And another really simple example is bullying. So whether it's at school or in the workplace, it doesn't matter where, but that bullying can really create a type 2 trauma for someone. And often the medical diagnosis, and this isn't in the DSM-5, though there were quite a few folks who were lobbying for it, but it's increasingly being recognized and being pushed for the DSM-6. So that's the Diagnostic Statistic Manual. So it's being able to diagnose illnesses and experiences, is the concept of complex post-traumatic stress disorder. And that really is focusing in on not a single instance, but how do you manage when it has been a betrayal of trust in primary relationships and in loving relationships. So the last type of trauma we're going to address today is generational or historical trauma. So these are often used in a bunch of different ways. There are some differences between them, but for our purposes today, we're just going to really focus in on how they're connected. So this type of trauma occurs to people that fundamentally changes the genetic structures of DNA. So the epigenetics change. So certain things get turned on and activated, certain aspects of their genes get turned off as a direct result of living under such chronic stress and trauma. When we consider generational and historical trauma, we see that the legacy of trauma is not just in the DNA, but also how folks have adapted and are living and reacting in the environment in which that trauma is happening. So coping mechanisms, whether healthy or unhealthy, right? The coping mechanisms that people develop to manage such ongoing and severe events are passed down to children, are developed among peers and colleagues, and are continued. So when we have ongoing traumas, we're really experiencing this active process of the changes to our genetics and the development of coping and adaptive mechanisms to try to manage the extreme stress that that person is being placed under. So some specific examples of what that looks like are living in a racist society and dealing with interpersonal and systemic racism every single day. So particularly for Black, Indigenous, and other people of color. So folks who identify as people of color. Other examples include living in active or former war zones, any types of or examples of genocide or ethnic cleansing and living through that, living in extreme poverty with chronic stress. And there's a lot of other examples out there. I'm sure you can think of some, or you know folks who have experienced some, or you yourself have experienced it. So another example, particularly related to our loved ones living with dementia, especially if they're a bit older, for folks who lived through the Depression, the Great Depression, or other economic recessions and periods of scarcity, people can get really fixated on money or food because those are often the things that are the most scarce in those conditions. And that is an easy way to see generational or historical trauma. Like my grandparents were very intense about using every single scrap of food available. And particularly for my grandfather, who did have Alzheimer's, like he got very fixated on making sure there was enough food in the house all the time as a direct result of having lived through the Great Depression in a farm family in a very rural area of Wisconsin. So you can just kind of see how that generational historical trauma shows up for people. So now that we kind of understand what are these different sources of trauma, let's talk about the reactions to trauma. And one of my favorite parts of talking about trauma, if there's like a favorite part, is actually teaching people what these 4 reactions look like, because for many folks, they haven't heard of anything beyond fight and flight. So when they get these other languages, it helps them understand what their kids did or what their very best friend does and why the best friend is doing that. So without further ado, there are 4 F's. So these are the primary reactions to experiencing a traumatic or deeply stressful event. Sometimes it can be just deeply stressful without the trauma, but it is almost always when someone's experiencing trauma, they choose one of these 4 reactions. And it's not really a choice. It's often unconscious. It's highly reactive. Like your brain just flips into that mode of like, that's the way that's going to keep us safe. And it can also be induced by experiencing or being exposed to reminders of a traumatic event. So it's not just when it's happening, it's even afterwards. So those 4 F's includes losing cognitive and memory-based skills through an illness like dementia. So we might see these reactions coming up for people because they're experiencing a trauma by losing their cognitive and emotional regulation skills. That can be really scary for people. So as loved ones who are giving care, attention, and building relationships with loved ones living with dementia, You have to be able to know and respond to these four main reactions to traumatic experiences. And again, most people use all four types of reactions at different times in their lives. So they learn different strategies around that. But we typically fall to one or two as our primary defense mechanisms. So when we're looking at each one with some example behaviors, so you're better able to identify when a traumatic reaction is happening, um, think about kind of like maybe where you might fall in this, like where do you lean toward? I know the two that I really fall toward most often. It's important to understand though, it is always a reaction coming from a place of fear. So even if like fight, people think of fight a lot, fight might seem really big and scary, but it's coming from a place of very, very deep fear and terror. So they're fighting because they think that's how it's going to save their lives. So on our little four axis, we have first and foremost fight because it's the easiest reaction to identify. It is also the easiest one to get frustrated with, I think, for most people. So when a person is experiencing or reliving that trauma because they've been re-exposed to those memories, they fall into a pattern of stress response that is focused on self-preservation, because that's all these are. These are stress responses focused on self-preservation. And the fight response is really focused in on aggressive behaviors. And if you'll recall from a previous webinar that we did, aggression is very different than agitation. And aggression is when you are using threatening behaviors or actions toward yourself or other living beings. Okay. So this is self-preservation through aggressive behaviors, escalating situations. It might involve accusations of others, even in things that they know didn't happen, demanding perfection. So it has to be perfect or it's wrong and it's not okay, and they're going to fight you about it. There might be the use of physical force, the use of emotional or verbal attacks, especially if it's a care and loving relationship. Something like parents, they might use emotional or verbal attacks. And then there can be other responses really grounded in using that force, aggression, or tactics relying on force to make the threat go away, because that's really what's happening. They're trying to make the threat go away to self-preserve. Specifically, when working with a loved one who lives with dementia, this could look like really aggressive distress. So, yelling, slamming things down, actual physical fighting, right? And it's not always like yelling with words. It could be vocalizations, like really increased vocalizations that sound like yelling. Those are all some really specific examples of what the fight response might look like. It could also include things like you stole my sweater, you stole my purse, and that really aggressive insistence, especially if they're like coming towards you and feeling very sure. That could be not an example of them being difficult or frustrating. It could actually be a traumatic response that they're having and they feel in danger. So the next one is flight. So these are the two that we hear the most, fight or flight. So flight responses happen when a person is experiencing that stress response and they're focused on self-preservation through leaving, exiting, or otherwise getting away from the source of threat. So it's just like what the name says and how we use it in our popular culture. This can also look like not just trying to like physically leave the threat, it can look like things like avoidance. So they don't want to talk about something and they don't want to acknowledge something has happened because it feels too scary to try to deal with it. It can also look like denial, so saying it never happened and they're fine, or some other type of coping tactic that allows them to really just get away from that feeling and get away from dealing with what has happened. So that can include things like the use of mind-altering substances or chemicals. So things like alcohol or prescription medications. Oh my gosh, I couldn't think of it. Prescription medications, or it could be illegal drugs or substances that they might be using to be able to just escape those painful memories and their experiences. So sometimes when we look at addictive behaviors, they might be rooted in a flight from some really serious trauma that they just want to make sure that they're self-preserving by not having to connect to it. So specifically, when we're working with our loved ones who live with dementia, this might look like a resident or your loved one, a person you're caring for, right? Whoever that might be for you, physically trying to hide from you. They might be trying to push you away really frequently. They might just try to get away, keep saying things like, I have to leave, I have to get out of here, I can't be in here. It could also look like things like demanding drugs or alcohol that they may have used previously in their life because they're just trying to escape having to relive those really terrifying experiences, emotions, and memories. So next is the freeze response. So the freeze reaction is hard to miss, but easy to misunderstand. It's when a person shuts down completely. So when we say freeze, think of it like they turn into a giant block of ice, essentially. So it's the human equivalent to an animal playing dead. So if you've ever watched nature documentaries, that's what I do in my free time. You'll see that animals like play dead when a predator is near. This is our human equivalent of that. So this is a pattern of stress response that focuses on self-preservation by waiting for danger to pass on its own. So this may look like someone actually freezing in place, not moving their bodies, but it can also be someone who's refusing or unable to speak or respond to what you're saying. So someone might be really, really emotionally high, like really big emotions, really like big process. They might be starting in a fight response and then it gets too threatening. And all of a sudden, all the emotions drop out of them. They get really quiet. They completely just fall like it's like a balloon being popped. They just like fall back in on themselves. That is a freeze response happening. So it might also include someone experiencing dissociation. So they're no longer really in their body. Their brain is making that break for them. It might also look like someone being completely unable to make even basic decisions. So even in my previous work, right, there I worked with several survivors that even asking a question of like, would you like a glass of water? They couldn't actually make a decision because they were so heightened in their reaction and they were so afraid. They might feel stuck, stiff, or numb. They might describe that they can't feel their bodies. That's part of the freeze reaction. Could also be really lowered heart rate and decreased breathing. So like you might see them like not breathing or breathing very shallowly. That's part of the freeze response. So specifically when working with our loved ones in dementia, it's going to be very similar things. It could look like someone shutting down in a conversation that they were really active in. It could look like withdrawing. So, and that could be not just in the moment, but a longer term withdrawal away from other people, or simply not moving or responding at all because they physically can't, right? It's an autonomic response, meaning our brain triggers the freeze response and we can't logic our way through it. We can't try to break through it. It actually requires all of those stress chemicals to release from the brain, lower in the body, in the bloodstream, for that person to come out of a freeze response. The last one that I think is really important to know, especially when working with folks living with dementia, is the fawn response. So this is the least known of the 4 Fs, and it is easily the one that is most misunderstood by everybody, myself included. So some people can look at the fawn response and think that person doesn't have a backbone. That's usually the phrase that I hear. They don't have a spine, they don't have a backbone, or they're a people pleaser. However, fawning as a pattern of stress response is actually focused on self-preservation through accommodating and minimizing a threat. Okay, so what this might look like for some people because they learned that this is what keeps them safe from life-threatening or life-changing events is excessive apologizing. So they're saying sorry for everything, promising to do whatever the person who feels threatening wants them to do. So saying, whatever you want, you got it. It could look like not holding any boundaries. So like you might talk about the event after the fact of the person be like, why didn't you tell them no? It might be part of a fawn response. It can also look like folks not asking for their needs to be met. insisting that it's their fault something happened, even when it's clear that it wasn't their fault or it was nobody's fault because it wasn't that kind of event. Agreeing with a source of threat, even when they don't agree, and you can kind of see they don't agree, but they're saying yes, they agree anyway. Fawning is really focused on an effort to keep the peace and prevent conflict that is perceived as dangerous. So it doesn't have to actually be dangerous for us. We might look at it and be like, that is not a threat to your life. If that person perceives it as life threatening or dangerous, a fawning reaction might follow very quickly. Stockholm syndrome is one of the most well-known examples of fawning. And if you've never looked that up, definitely look that up, right? It's when you side with your attacker or oppressor and say, like, I'm with them now. I agree with what they're doing. So when we're working with our loved ones who live with dementia, this might look like someone following you around a lot after something upsetting has happened or they've been re-triggered. They might compliment you repeatedly or babbling. So they're following you around, babbling at you, trying to get you to respond or like laugh or smile in particular, because laughing and smiling from a source of threat is a very easy nonverbal way to see that that isn't really a threat anymore. So they might be trying to get you to laugh or smile at them. They might be agreeing with everything you say, saying yes, 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 or lots and lots of apologizing when it doesn't make sense for them to be apologizing. That might actually be part of a fawn response, that you got to pause and say, what do I know what's happened here? What do I know about this person's history? Has something triggered for them? So maybe on the TV, for example, there was a really extended scene of a car accident that person might have actually lived through a really, really life-changing and really terrible car accident. So that has triggered in their brain, but they don't have the skills at this point to be able to say, I just saw this car accident. It was really upsetting for me. So they're following you, they're complimenting, right? They might be engaging in that fawn response or any of the other 4 Fs. So now that you know them, hopefully you're going to be able to see them and name them a little bit differently, not just with your loved ones living with dementia, but everybody in your life. I find that it's very helpful to be able to name these for people because they don't always know what's happening for them, particularly folks who are experiencing the freeze or the fawn response, because we just don't know them as well unless you're in the work on a regular basis. So to just summarize our trauma 101 section, I really love this quote from Lemony Snicket. Just because you don't understand it doesn't mean it isn't so. This is the most important lesson, the most important thing you can take away from this first section. If you don't take away anything else, please take away this message. Just because you don't understand it doesn't mean it isn't so. And what this is really telling us is we may not understand why something was a trigger for a person. We may not understand why someone experienced the exact same event or a very similar event to us, and they are traumatized and we are not, or vice versa. We don't have to understand those things to choose compassion, kindness, and a trauma-informed approach. We don't have to be able to look at it and say, I see it exactly as you do. The most important thing every time is to just acknowledge that something really bad and scary is happening for that person and choose compassion, kindness, and trauma-informed approaches whenever you can. So let's now talk about some practical information. So let's talk about trauma-informed care and dementia. So especially when we're applying it to regular contact with the people that we love. You know me, I want to give you a little bit of research so you know that what I'm saying is grounded in something other than just my thoughts and opinions, even though those matter, of course. So what is really important to know about the connections between dementia and trauma is that often folks have that inability to identify. So someone living with dementia has an inability to identify what is a memory or what is a current event. That is one of the most important connections that we have between trauma and dementia. Because when they're experiencing a memory as a current event, especially if it's a traumatic memory, that's going to replay multiple times for them, most likely. So it's not going to be a one and done situation because dementia often doesn't work that way for us. People get stuck on particular or key events that happened in their life, both good and bad. And as we talked about earlier, living with and managing a life-threatening or terminal illness is a potential source of type 2 trauma for individuals, and that includes loved ones. You might actually be experiencing long-term trauma as a direct result of loving someone who's living with dementia, especially if you're a direct caregiver for that person. So if things I'm saying are kind of like sticking in your brain, please know there are so many resources out there. I will send out that resource sheet in the next couple of days. I don't want to commit to tomorrow. It might be by Monday. So let's now talk about the actual research. There is a very specific link between dementia increasing the risk of reliving trauma. So this particular research by Flannery and Flannery, has demonstrated that the relationship between dementia and reliving untreated or treated, that's a big one, psychological traumas that have happened through the life course, it comes up again and again for folks living with dementia. So this particular research demonstrated the important role that caregivers and loved ones have in helping those living with trauma be able to actually manage the outward expressions of trauma. Because folks living with dementia often cannot distinguish between what's happening right now and what's a memory. And they might not have the emotional and cognitive skills and abilities to process what's happening. So caregivers and loved ones are a key source of helping people work through it. So even though dementia increases that risk, the people around them and how they respond can help diminish the impact of those experiences. So combat veterans with PTSD have 2 times the risk. So veterans with PTSD, particularly so for those who are military or veterans, had a 7-year cumulative incident dementia rate of 10.6% within the population. Veterans who did not have PTSD had a rate of 6.6%. That's almost half the rate. So with age as part of the time scale, the proportional hazard model, so this is a little bit of research talk, but it indicated that patients who had PTSD were more than twice as likely to develop instant-based dementia compared to people without PTSD. So folks who have lived through really intense combat experience are much more likely to develop dementia as a direct result of those changes that are happening in the brain because of that those reactions and those stress responses. Additionally, some research has talked about, so this particular one is a very systematic review of 25 peer-reviewed journal articles pertaining to dementia and post-traumatic stress disorder. So it's like it's a meta-analysis looking at everybody who's looking at this and saying, what are the trends among all of this research? So what they found was post-traumatic stress disorder in midlife was reported to increase the risk for late life dementia of all types. Late onset Alzheimer's disease and vascular dementia were reported to increase the risk for delayed emergence, the re-emergence, and the worsening of post-traumatic stress disorder. So PTSD increases the risks of dementia, and dementia itself is increasing the delayed onset and the risk of PTSD coming back again and again. So what this research told us by looking at all these articles is early life trauma can be re-triggered by dementia. So it's really important to understand that interplay. So the last big piece of research that I'm going to give you, and I think it's so important to really understand, like, it's not just all doom and gloom. The world still is witnessing genocidal violence. It is witnessing racist violence and really other traumatic events that are happening. being reflected in different ways when caring for survivors with dementia. So this particular research looked at the effect of person-centered care, which is a specialty of RACMA, looked at person-centered care and asked, how does this impact, change, or help people who are reliving that trauma because they're living with dementia? So what they found is having that awareness of what it means to be a survivor of severe trauma and having that person-centered care actually makes it possible to avoid negative triggers. It also helps people confirm their emotions and experiences. And it actually comforts people during negative flashbacks when it's a person living in dementia care settings and environments. So what this research found was that nursing assistants, their patients, so their emotional patients, not their people they're caring for, their patients and their empathy was actually supported by a wider understanding of the behavior with people with dementia who've survived trauma when placed in a person-centered context. So person-centered care, just to sum it up, really does help alleviate the dementia trauma connections, which is why knowing the person you're working with and really understanding who they are as a human being across their life course, if you've known them that long, but even who they are now, can really truly help make it easier to live through the worst parts of trauma. So let's get going on what trauma-informed care is. So this is an overview slide. We will jump into the 6 specific dimensions of trauma-informed care next. So in the simplest of terms, trauma-informed care is a series of actions, habits, and policies of an organization and its staff, because this is really looking at organizations, but you can use it in your own life. Looking at policies of an organization and the staff to account for the widespread nature of trauma histories. And it is also trauma-informed care as an approach that takes steps to prevent re-traumatization and reduce the effects of trauma on a person. So it's not just seeing that it's there, it's making sure that we're taking steps to do something differently and make sure we don't put that person through that again. So one of the most important parts of trauma-informed care is starting from a position of knowing how widespread trauma is. Like we gave just a couple examples in the beginning. It's really unlikely that someone hasn't lived through something that is traumatic to them. So nearly all people are living with some difficult or painful memories, and many people are living with trauma history. So some research estimates give that nearly 70% of all adults have at least one traumatic event in their lifetime. So 70%, that's 7 out of 10 people. That's a lot of people. 1 in 13 people will develop post-traumatic stress disorder or similar or related disorders at some point in their lifetime in response to those traumatic events. So those living with dementia, as we talked about in that research slide, are at much higher risk. So we should just, as people, assume the likelihood of trauma in someone's history. So another aspect of trauma-informed care is really about staff members, if they're living in a particular facility, but also family, friends, and loved ones, being able to recognize the signs and the symptoms of trauma. So if a trauma response does become present, everybody knows what is happening and what to do about it. That's why we spent the first half of this webinar really giving that information so you can identify what's happening, because that's how we get to trauma-informed care and approaches with our loved ones. So not only knowing what trauma signs are and what symptoms look like, it only matters. So knowing that stuff only matters if we're going to take action based on that knowledge and start using trauma-informed principles and approaches in our day-to-day work with our loved ones and our day-to-day relationship building with our loved ones. So whenever possible, we want to respond fully using trauma-informed care and integrate those principles of trauma-informed care into every single contact that we have with our loved one. Finally, trauma-informed care is focused on building resources and routines to prevent and resist anything that might re-traumatize a person. So I want to give you a really specific example. Um, you might be a family member or a loved one to someone who lived through the Holocaust. Okay, so a Holocaust survivor might be really re-traumatized by seeing a professional in a white lab coat. So you might be taking them to the doctor for a routine medical appointment that they've been to a million times before. And being in a sterile environment, having somebody in a white lab coat might actually re-trigger that trauma of living through the Holocaust for them. Additionally, a Holocaust survivor might be re-traumatized by being told to go to the shower. So if you say, go to the shower, like get to the shower, we're going to go to the showers, that those are phrases that were used against Holocaust survivors, and they were being told that they were going to die. So it's really important that if you have a loved one, and this is just like one tiny example of how we resist re-traumatization. If you have a loved one who lived through the Holocaust, making sure to wear like normal clothing, or talking with medical care providers ahead of time and letting them know, and asking them to change into like a smock or a colorful top, something very simple like that can really resist that traumatization. If you're working with your loved one and you know that they need to take a shower, but you know that they lived through the Holocaust, saying something as simple in your language of, I'm going to go get a bath ready for you. You might actually not be giving them a bath, like helping them with a bath. You might actually be helping them with a shower, but just changing your language is such a quick and easy example to understand how we can prevent re-traumatization by just understanding the trauma and being able to really respond and integrate what we're learning about our loved one. So let's talk about our 6 core principles. And these are principles you can use in every relationship you have with everyone, even if it's not someone living with dementia, even if it's not, in your working environment, you can use this with your loved ones on a regular basis. So the 6 core principles of trauma-informed care are these 6, okay? So we're gonna go through each one. Oh, that animation is not quite right, everybody. So we're just going to go through it together with what we got. So the first one is safety. Safety is about ensuring physical, emotional, and psychological safety. So we can provide a sense of safety to our loved ones when we just slow down, assess the cues that we're seeing in our loved one, and reassure them that they're safe. So just taking a moment, if you see someone starting to like freeze response and like really tighten up and panic and get away, that's a little bit of freeze, a little bit of flight, maybe. Pausing and saying, hey, I see you're really scared. I'm going to take a minute. Let's just take a second together and breathe. By providing that time to develop that trust again, to rebuild that emotional response by demonstrating patience, we can increase our loved one's sense of safety and more effectively help our loved one who's re-experiencing trauma. So just by really pausing and like really safety, if I had to boil it down to a single thing you could do, just slow down. We want to move so fast in every part of our working lives, in our personal lives. We got to like go, 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 go. Safety is only ever really built by taking time. You can't rush safety. So if nothing else, just slow down. Just take 3 minutes instead of 1 minute. It's going to save your loved one a lot of stress, trauma, and upset. And it's also going to save you a lot of stress, trauma, and upset. And it's going to increase the quality of your relationship together. So the next one is trustworthiness. So this is really about building task clarity with your loved one. So being very clear on what you're doing and why you're doing it. Having consistency with your loved one. So even if they don't really fully recognize time anymore, calling at the same time every day because you said you were going to call at 6 p.m. every day, that builds trustworthiness with someone. The other part that really builds trustworthiness is having strong interpersonal boundaries. So I'm going to give you something really simple. It's just as simple as not expecting your loved one to be the exact person that they were to you in your life. So your loved one is changing. when they live with dementia. They might not remember you as their spouse. Having strong interpersonal boundaries of not asking that person to try to remember you as their spouse. You know who I am. That's like something that happens. You know who I am. Come on, you can remember. That's really trustworthy eroding. So it's like makes you less trustworthy because you're putting that person under a lot of stress. So just having that strong interpersonal boundary of saying they're not going to recognize me as their spouse. I know that I'm their spouse, and that's what matters most is having this functional and really positive relationship as we can now. So, through being really clear and consistent in routines and habits wherever you can with your loved one, maintaining those healthy boundaries wherever possible with your loved one, we can really increase that trustworthiness and reduce re traumatizing our loved ones. Choice is such a big deal. Choice is so important. Most people don't like being told what to do. So, wherever we can, as part of our core principles of trauma informed care, we want to make sure that our loved ones have control and the right to make decisions for themselves whenever possible. So, of course, there's a bunch of laws. There's the Bill of Rights, there's person centered care approaches, there's vulnerable adult laws. There's like so much involved of the culture telling us that choice matters. So, for you with your loved ones, providing just really simple choices for your loved one living with dementia. So, holding up a shirt with visual cues, the pink shirt or the blue shirt today. Too many choices is overwhelming, as we've talked about in past webinars. So, just giving one or two choices is a really important opportunity to build in that trauma informed care principle. So, listening when your loved one is expressing that they're unhappy about a situation, and then taking action on their requests whenever you can. So, if someone wants a Diet Coke, but you don't have a Diet Coke, really saying, hey, I'm so sorry. We're going to go get that later today or tomorrow, whenever you're going to run to the store. Right now, I can give you coffee or tea. Which one would you like? Just rebuilding that choice wherever we can as a way to make sure we're not re traumatizing people. Because again, folks living with dementia are adults who've lived long, complex lives. They were self determined for most of their life. That choice is a key part of how we really make sure that we resist re traumatizing someone, especially if they have type 2 trauma that was really focused on betrayal within a loving or caring based relationship. That choice matters. Next is collaboration. So, making decisions together with your loved one, involving them in the conversations about what's going to happen, even if your loved one is no longer verbal and can't move very much. So, even if they've lost physical mobility and verbal skills, still talking to them, looking for any kind of response that you can get from them, making sure you slow down and you give that 20 seconds of dementia friendly communication strategies. These are critical ways we develop that collaboration. So, collaborating as a team. So, that can also look like working with care partners. If your loved one lives at Rockma or you're involved with Rockma, or if they live at a different facility, really meaningfully working with care team members, the nurses, staff. That's a core action around collaboration of making sure that you are advocating for your loved one and that you're also listening to your loved one and making sure that you're responding to their needs and any kind of distress that they are exhibiting. That's all part of a collaboration based approach that really resists re traumatizing because most people don't want to be spoken for. We can speak with, we can speak to, we can involve them in the conversation, even if their responses aren't going to look like a verbal response. It's such a small thing you can do, but it really builds the relationship between you. Next is empowerment. So, empowerment as a core principle is about prioritizing knowledge and skill building for your loved one to remain as autonomous or self directed as possible. So, empowerment when working with your loved one who's living with dementia is going to look a little bit different than I think we would normally think about empowerment. We want to make sure that we're working with our loved one to hold on to their activities of daily living or they're just like basic day to day skills as much as we can. So, how we can do that is by choosing the least restrictive intervention possible. So I'll give you a really quick example. If you're working with your loved one and they need to brush their teeth, right? They might struggle to brush their teeth. It can be a really easy solution for you to just do it for them, grab that toothbrush and do it. But that's not really an empowerment-based model, and it's not helping them retain the skill of how to brush their teeth, even though we know they're going to lose it eventually. So we would want to start with maybe first modeling. So we would grab our own toothbrush and say, okay, so we're going to do this, right? If the modeling doesn't work, then we might take the next step and put the toothbrush in their hand and then model again. These might take you a few more minutes with your loved one, but it's a key component to how we really build that loving relationship. It's a key component of how we prevent re-traumatizing our loved ones, especially if their choices, their opportunities, and their ability to live as a self-directed person was taken away from them in a traumatic experience at a different point in their lives. So the last big one is predictability. So predictability is about ensuring that our loved ones have as much routine, forewarning, and ability to plan for changes as possible. So we've talked about it in other webinars that predictability and routines are key ways we can support people living with dementia. It's one of the most important ways we can support someone living with dementia. It's also one of the key ways that we support people living with trauma. And those two are very connected, as we've talked about. So providing your loved one with really simple warnings, like, I'm going to lift your left leg on the count of 3. Are you ready? So you're not necessarily giving a choice because you got to lift their leg because maybe you got to take their shoe off. Just giving them the warning, telling them what's going to happen, waiting those 20 seconds to use your communication, your dementia-friendly communication, or using signals and visual cues can really help you live out this very core principle of predictability. It's all about just making sure people know what's coming next. So let's talk about a couple of specific supportive strategies for trauma-informed care within dementia care for our loved ones. So first, listening and paying very close attention to our loved ones' needs, expressions, and requests are some of our greatest tools to build up that trauma-informed approach. Through listening very closely to verbal and paying very close attention to nonverbal cues, we can start to identify trends or patterns of behavior that might indicate someone's struggling with a trauma history. Take notes about your loved one, especially if they're living in a care-based facility. Take notes, document, share what happened or what worked or didn't work. Really focus in and start keying into those verbals and nonverbals because they're going to change over the course of living with dementia. So we got to build as much skill and knowledge as we can as early as possible. Share and document stories or issues that might come up again and again. As family and friends, you are going to know stories. You are going to know issues about your loved one that nobody else does, especially if you've had a very long and close relationship. As you discover those key stories, or if you already know them, sharing what you know, documenting what you have learned or observed over the years of loving that person are such important steps you can take to help really increase resisting traumatization and really living out that trauma-informed care. Because eventually we know that dementia takes away the ability of our people to advocate for themselves, to manage their emotional and cognitive process. They might not be able to tell the story that happened to them and why they're afraid or why they're having a trauma reaction, one of those 4 Fs. So we have to be able to share and document, to be able to advocate and get better services for our loved ones. And in regards to providing specific details about prior trauma histories, it can be very painful or embarrassing for a person who lived that trauma, or it might be really painful or embarrassing for a family member, right? Those things can happen, but in order to provide really quality care and follow those 6 core principles, we want to be able to give details but not necessarily the full specifics of a story. So something as simple as sharing and documenting their dad abused them as children. That's going to be really important information. It's not telling all the dirty details of everything that happened to that person, because that's not really our story to share if we can help it. But just that high level overview of that person's dad abused them as a child. That can really prompt care providers, that can prompt other loved ones to understand that maybe a masculine presenting person coming into that person's room to do bed checks at night, or to go check on that, like maybe the person's living in the home with you, and you're a masculine identifying person, and you like roll up to their bedroom in the middle of the night, that might prompt a trauma reaction because of that prior history. So you don't need to share all those details. It might not be appropriate to share those details. Another example might be she experienced a sexual assault when she was 23. Not all the dirty details, because that's not really relevant to us, but acknowledging that it happened is going to be really important. So it helps us understand that we got to go really slow, right? And for you yourselves, you got to go really slow when helping someone with their perineal cares, like after going to the bathroom, especially if they have a prior assault history. Getting that permission first and providing lots of verbal warnings are ways that we can really truly live out those supportive strategies. Again, if we don't know about a trauma history because we're too afraid to share, we may not be able to prevent re-traumatizing our loved ones. So wherever you can, document at a high level of some things that happen so we can respond as a collective community caring for our loved ones. Create allies and support systems for coping. Trauma histories can be triggered at any time. This is especially true for people living with dementia, but it's also true for us as family members and loved ones. Trauma histories can mean that a person is reliving those traumas in the present. So we got to be able to really pay attention, figure out who is someone that can help us and what kind of support systems are best. What is the most effective method for supporting our loved one and getting them what they need to be able to move through that trauma moment? So really building up your allies, really trying to like engage and partner with everyone you can in your loved one's life. This one's so easy for the most part. Avoid any known trigger. So this is where that paying attention and documenting your loved one's history and responses really pays off for you as a person. But it can also really help if you are providing that information to care partners who are taking care of your loved one. So like identifying if a particular sound or sight or items might trigger a trauma memory for a person living with dementia. So, right, one easy example is if a person was a combat veteran, hearing loud booming noises can trigger traumatic war-based memories because it sounds like explosions or gunshots. Another example from someone that I worked with is the sound of a leather belt through jeans was always a sign that they were about to be abused by their father. It's such a weirdly specific noise, but it's such an important noise to know because that person, every time they heard it, would start shaking and start panicking. It's really simple stuff like that. Identify those known triggers and prevent them from happening wherever you can. And if that noise happens anyway, or if that trigger, they see something, hear something, smell something, taste something, if something is triggering for them, take note of it right away, help them through that process, and then do whatever you can to avoid it in the future. Validate people's concerns. Like this is super basic. Validate that it's happening. Tell them that like you hear them and do something with the concern, right? Folks living with dementia may not always have the greatest grasp on what reality is right now, right? They might be experiencing visual hallucinations. They might be experiencing flashbacks. Always follow up anytime there are concerns or distress. And especially if someone has a strong trauma reaction, reacts strongly to another person, or is potentially hurting themselves or others trying to protect themselves. Validate, follow up, do something with it. So now I'm going to give you a bunch of really specific phrases that you can use if you don't know what to say when someone's experiencing trauma. So I think the most important thing that frames this up is having a basic sense of empathy. So Dr. Brene Brown said, empathy is communicating the incredibly healing message of you are not alone. In reality, That's what most folks who are experiencing trauma need the most. Not that you had the same experience as them, but knowing that they are heard, that they are validated, and that you're there to weather the worst of the storm with them. It didn't happen to you, but you can sit with them while it's happening. So here are some phrases that you can use if someone's experiencing flashbacks, traumatic memories, or other distress behaviors to really bring down that response. I can see you're scared. I'm going to wait here until it's okay for me to come closer. So it's really pulling on choice, empowerment, pulling on that sense of safety, those 6 core principles, really pulling that in. A phrase as simple as, let's take a break and try again later. Really simple. So if things aren't going well and you can see that distress is heightening, they might be experiencing some triggers, just acknowledging what you see and taking time. I can imagine how upsetting, scary, lonely, fill in the blank with whatever would be an appropriate word there, that must have been. And if that feels a little too awkward, even saying something like, I would have felt that way too. That's really making sure that they understand they're not alone and you're there. You're not there to fix it. You're not there to make them feel better. You're not there to make it go away. You're just there to hold it with them for a few minutes. Thank you for trusting me enough to tell me. Seriously, if someone discloses something to you and you have no idea what to say, that sentence, thank you for trusting me enough to tell me, is one of the most important sentences you can say. I have worked with so many people over the years of my career, and they've told me some real things that I didn't, even as a professionally trained victims advocate, I didn't know what to say because it was that severe and out there. Simply saying thank you enough for trusting me to tell, like, thank you for trusting me enough to tell me. And or saying something like, I am so sorry that happened to you, can be one of those powerful ways to acknowledge what's happened and connect. What can I do to support if your person has enough skills to be able to respond? What can I do to support you? Can I go get you something to drink? Can I go get you a snack? Can I go get you a blanket? Anything along those lines of just affirming something's happened and being supportive in that process. And the last one is, I believe you. So many folks who've experienced trauma have been told that their trauma didn't happen to them. It didn't happen the way they remembered. It wasn't that bad. We're taught in so many ways that what happened to us isn't valid. So just saying, I believe you, or what happened to you wasn't your fault, can make a world of difference for people. The most important things about these phrases is that they acknowledge what has happened and how the person might be feeling. There's no judgment. There's no trying to fix it. It's just an offer of connection. When someone is struggling with traumatic history, especially if they think it's happening right now, you have to acknowledge and identify feelings in a judgment-free way and build those offers of connection and support. So, kind of pulling it all together, this is our trauma avocado. So, there's going to be so many instances in which we can help by simply being present and using trauma-informed care principles in our day-to-day relationships with our loved ones living with dementia and pretty much everybody. This is a great, I just love this image so much. This is a great way to understand how trauma recovery happens. So that outer peel is often like, yeah, you're fine. That middle is kind of those squishy goo, the feelings, the symptoms, the triggers, and the pit is where traumatic memories and the beliefs about the self or the world that are based in trauma and shame live. So trauma recovery might have occurred earlier in somebody's life, but our loved ones might be being re-triggered, even if they've already kind of worked through it in their life. That pit might come back for them, that squishy goo might come back for them. So that healing that someone might have done goes. So as loved ones, we have to know and understand that trauma may come back many times. You may be in the pit with that person and dealing with the pit many times before they're able to either forget those memories or be able to move through those memories. We can sometimes be able to help them stimulate healing, and sometimes we just can't. It's easy to see people reliving trauma as a problem or being difficult, but trauma creates long-term changes, and the symptoms of trauma actually mirror challenging traits in people. So it's important to just take a breath and ask, Is this trauma? The last thing to say, and this really is our final kind of note, our best effort to help another person move through traumatic moments come through being a connection, come through being supportive, and come through validating someone's experience. We can also support healing in the moment as well as long term by being aware of those trauma histories and working to resist re-traumatizing through every single action we take with our loved ones. And by trying new ways of supporting our loved ones, even if it doesn't feel easy right away, just being there. That's what this image really represents to me. Getting down on their level, seeing it from their perspective, and letting them know that they are not alone is one of the most important things that we can do in helping someone move through trauma, and really using trauma-informed strategies in every aspect of the care that we give to our loved ones living with dementia. So that takes us right into questions. Thank you so much for joining us. I know it's 7:14, so if you got to bounce, that's a-okay. I just want to open up the line. If anyone has any questions, you can go ahead and unmute yourselves and throw it out there. And if not, we'll just wrap it up and call it a day.
Very good information. Thank you. It was awesome. Very good.
Excellent.
Yes, one of John Anna's best again. I think
Thank you.
everything you say here is so essential, and I assume that as your role in training that you are that this is very important. What you train the staff to do, and the listening, and the looking forward to, and just not rushing through things. I think it's all such critical information. I'm happy to have it myself. Yeah.
Thank you so much. Truly, thank you so much. I just want to make sure, does anyone have any questions or anything that they want to explore?
Did you see the chats?
Oh, yeah. Oh, a couple of folks had to.
Just Sean had to check off early, and Marnie said it was great. I loved it.
Oh, thank you so much, everyone. So I guess we'll just do my wrap-up slide here. Thank you, as always, for joining us. Please connect with Rachma. You can call us at our main line. We're on Facebook or Instagram, and Marcia does a great job of posting information. She always posts about these webinars. So if you aren't sure where to find them, go ahead and hit up our Facebook and our Instagram. Drop a like, drop a comment, come hang out with us. Great. Again, as always, if you got to get a hold of me, Jay Gans, and I will send the survey, the post-webinar survey. It takes about 3 minutes to fill out. You'll see that when you receive all of those materials when I send them out. So thank you so much. I'm going to go ahead and stop our recording. Oop.
Thank you.
Thank you so much for coming. I forgot I had a reference slide. Okay, reference slide just for the recording. Thank you again, everyone.